Tony, I'm going to pick on you. Tell me, just remind our audience about the REGO study and its role in the setting and the like.
Yeah, so
quick summary.
So regorafenib, as you know, is a multi-kinase inhibitor, i.e. a dirty drug in terms of it hits so many targets, a multitude of targets, and a lot of them are relevant, or most of them are relevant to cancer or microenvironment, etc. So the study that essentially led to regorafenib coming to our practice was the CORRECT trial, which really randomized regorafenib versus placebo in patients with refractory metastatic colorectal cancer, showing a survival benefit and a PFS benefit. There was a follow-up study, Asian study, with the CONCUR trial, which essentially was in Asia, same design, but patients were less pre-treated because of the nature of essentially treatment patterns.
Less access
to biologics. Yeah. Mm-hmm. And again, very similar trends, except what was interesting is the deltas were actually quite more significant, which suggests that this agent works even better when patients are less pre-exposed in those patient populations. You know, so the efficacy has been established in those two studies. The safety of this drug is very similar to a lot of the tyrosine kinase inhibitors, although I must say, you know, when we see those patients, they've been through a lot of therapies, their performance status is typically compromised. But what stands out from this agent is you see hand-and-foot syndrome, and you see it quick within 2 to 3 weeks. It's pretty severe in about 10–15% of the patients. It does respond to dose, and we'll get to what we do with that. And then you see some of the VEGF toxicities, less so. It's not a.
Hand-foot fatigue. Watch the liver.
Fatigue and the liver. You have to watch the liver. You see elevations in LFTs and a little bit of bilirubin. You know, fatigue is interesting. Fatigue is very confusing in this patient population. There's probably some added fatigue from the agent, but you see it across the board with other agents, even capecitabine and TAS-102, when they're used in this patient population. You see more fatigue.
So can I drill down on the dose a little bit?
Please,
You're running the study looking at different dose and schedules. 160 is tough. Some can give it, some not. 80, we're worried it's too low. What's the study drilling down on?
So we have the study, and it's about to complete. Actually, we're on the last few patients, hopefully presenting this at ASCO GI. It's called the REDOS study. It's a 120-patient study, randomizing patients to 160, so the standard dose, startup, and then 80 escalating to 160 on an every week basis, 120, and then 160. The key, so there are multiple components to the study. In addition to just comparing the two dosages, you know, we're doing what I think we should be doing in clinic. It's the first month of therapy. You have to follow these patients on a weekly basis and adjust the doses and take care of the toxicity.
Let me ask the gang, starting dose in a patient off study, Paul?
120 usually.
120.
Depends on patient. Between 120 and 160, I would say 50% of my patients.
Yeah,
frail, 120. Fit patients, I would start with 160.
I will select carefully the patient. The patient should be really PS0 for being treated with regorafenib. Discuss with the patient. He has to come back to our hospital at least once a week for the first 4 weeks. And usually, toxicity 160 is very quick in the first 2 or 3 weeks of treatment. And so these 2 or 3 weeks are very crucial. We have also a trial that is running in Europe, a little different from yours, that compares the standard dose with a different approach that is basically in the first month doing 1 week on, 1 week off. Because in this way, you know, you can manage better the toxicity and the recovery. And then, according to what happens in the first month, then the patient goes over for the consecutive months. I don't know if this will work or not, but clearly, if you do 1 week on, 1 week off, and I wonder why, since the beginning, we have discussed a lot about the dose, why these things were not done before, because, you know.
So, you know, very quickly from phase 1 to the big phase 2.
And what I can tell you, about 60% of our patients go down to 120 if they start at 160 in 1 to 2 months.
Yeah, it's quick.
So
But I wanna-
very few patients can stay for 160.
It took really my switching this to PS01 patients to find this, but I now have patients on the so-called tail of the curve where they're stable
Yes.
beyond 6 months.
Yeah.
And my initial reaction to this wasn't a drug that was going to catch people,
Yeah.
and it probably isn't. If you're falling quickly, it probably isn't going to catch you. But have you all got tail of the curve
Yes.
patients?
Yeah, we just recently,
Many.
we are in publication with our consecutive series of 123 patients. So we had 28 of these patients carefully selected because they were PS0
They were good
or
patients.
PS1, good patients that you can invest on this kind of treatment. And 28 of them, that 28 out of 123, did at least 7 cycles of treatment. And there is a small tail up to 1 year and a half or even to 2 years. Obviously, you go most of these patients down to 80, even to 80 milligrams.
Yeah.
But you change at least the history of the disease in these patients.
Yeah, I just had a patient at just minor progression after a year on
Yeah.
treatment, and sometimes on 120, sometimes on 80, depending on the month.
Yeah, I have a patient who went almost 2.5 years on Regorafenib at 80 milligrams.
Yeah.
So it's clearly changing the biology. of
Absolutely.
the
It is.
disease.
It is a very interesting agent. You know, I think it's a learning curve, like all TKIs. You know, you have to think the challenge is the patient population at that level. A drug that's active but has its toxicities. So it's a learning curve. And once you learn how to use it, it's actually for the selected patients. It's a very effective drug.